Hi, everyone. Welcome to Breaking the Silence, a podcast produced by Angels Protection, Inc., where we amplify the voices that challenge inequity, advance health justice, and strengthen the healthcare systems that shape the lives of individuals, families, and communities. I'm your host, Makaila Davis, founder and chairwoman of Angels Protection, Inc., and today's episode is part of our Men in Medicine series, where we spotlight physicians whose work extends beyond patient care, leaders who are advancing research, educating the next generation of clinicians, and transforming healthcare through innovation and service. This series exists because medicine is more than diagnosing disease. It's about prevention, it's about education, it's about access. And it's about ensuring that every patient receives compassionate, evidence-based care, regardless of where they come from. This conversation is more, um, to me personally, it's about restoring quality of life. It's about improving outcomes, it's about reducing disparities, and it's about creating healthcare systems that prepare patients, not just treat them. For far too long, chronic kidney disease has remained a silent epidemic, with millions of Americans unaware that they're living with kidney disease until it significantly progressed. Too many patients encounter barriers to specialty care, education, transplantation, and home dialysis options. And today's guest is working to change that reality. Dr. Baseman is a board certified nephrologist and assistant professor of medicine in the section of nephrology at the University of Chicago. His career reflects a commitment to improving care for patients living with chronic kidney disease, end-stage kidney disease, acute kidney injury, and hypertension through clinical excellence, research, education, and innovation. After earning his bachelor's degree in biology from the University of Wisconsin-Madison, Dr. Baseman received his medical degree from St. George's University School of Medicine before completing his internal medicine residency at Lutheran General Hospital and his nephrology fellowship at the University of Chicago. Today, his clinical focus centers on improving outcomes for newly diagnosed end-stage kidney disease patients by developing a transitional care dialysis unit designed to better educate patients, improve transitions into dialysis care, expand access to home dialysis therapies, and increase referrals for kidney transplantation, particularly among underserved populations. Beyond his clinical practice, he's an accomplished researcher whose work has advanced the understanding of cephus-associated acute kidney injury, dialysis care delivery, chronic kidney disease, hypertension, and electrolyte disorders. He's authored numerous peer-reviewed publications, contributed to textbook chapters, presented grand rounds across multiple institutions, and continues leading innovative research focused on improving kidney acute nationwide. He's equally passionate about physician education. As an educator, he mentors residents, fellows, and medical students while helping train the next generation of nephrologists and physician leaders. Outside the hospital, he volunteers with the National Kidney Foundation, Kidney Mobile, bringing kidney disease screenings and education directly into communities, reflecting his belief that prevention and early detection remains among medicine's most powerful tools. What sets Dr. Baseman apart is his commitment to combining clinical care, research, education, and community outreach, ensuring patients receive not only outstanding medical treatment, but also the knowledge and resources needed to take ownership of their health. So today, I just want to take the time to welcome you to the podcast today.
Thank you so much. What a wonderful introduction. Thank you. Means a lot, and I'm excited to participate in today's discussion.
Yes, and it's all the work you've done.
Mhm.
So grateful to have you on to share
Yeah.
your expertise. So I kind of just wanted to start by asking, what first inspired you to pursue medicine and ultimately specialize in nephrology?
Yeah, it's an interesting question. I think a lot of people, physicians in particular, will say my family had a doctor or something. I'm the first physician in my family. So when we were navigating the process of medical school and things like that related to the application process, didn't really know much. And when I started medical school, I didn't have any sort of preconceived notions about what medicine is, other than I knew my PCP growing up as a kid. Um, and when we started the nephrology section of physiology, I just loved it. I just fell in love with it. And physiology, for those maybe not aware, is sort of the chemistry, the biochemistry, and the mechanisms by which things work in medicine. So, how the kidney does its job, how the heart does its job is physiology. And just fell in love with it. And when I was speaking to my colleagues, they were like, oh, this is the worst. This is so hard and challenging. So I kind of knew from then on it was going to be probably nephrology, but it was cemented during the pandemic. So I was a resident during the pandemic, an intern actually. And we went from having typically you have 2 months of ICU time during your residency training. I actually had 11 months. So because we need the demand is so high for ICU care. And the ICU is all about fluid management, fluid balance and AKI, which is a form of kidney injury, and management of that, as well as the ventilators and associated critical illness features. I just knew that nephrology was my future. Um, and medicine's a wonderful field, especially if you want to use sort of education to help people directly. And there's a lot of things that can do that, right? Social work can do that, as well. But it's a wide-ranging field, and there's so much to do in medicine. So that's what really inspired me to stick in there.
I love that. And also that, part of your story is being a first generation medical doctor, um,
Hmm.
and having to navigate all of that and then seeing where you are now.
Yeah.
You just completed residency not too long ago.
Hmm.
And I know we'll get into a little bit of your research too, but having so
Yeah.
many peer review articles and everything you've done in a little bit of time, it's
Yeah.
really
Thank you. Yeah.
amazing. So I also kind of wanted to ask too, was there a particular patient or experience that confirmed kidney medicine that was your calling?
Yeah, looking back at it, my mother, she actually died from kidney failure. And I'm remembering that process when I was in college when that happened. Was really impactful for me after I started medical school and after I started my residency training, because I was able to look back at that and remember how I felt on the other side when I didn't know a lot about medicine yet. I knew all the, math. I knew calculus, I knew chemistry, but, understanding medicine, well, I did not yet because I was only in college. And remembering the big dynamic difference between being a physician and being on the patient side. Um, I'll never forget that. And I always try to remember that with my patients. And that really cemented my interest in medicine, but also in nephrology because of, how things transpired.
I can see that. And it's really important work what you're doing and how you can relate that to your own personal experiences.
Hmm.
So you're making sure that those families are feeling that best care.
Yeah.
And also, too, I wanted to ask, so chronic kidney disease, it's often called a silent disease.
Yeah.
Why is early detection so important?
Yeah, I think that there's silent killers, high blood pressure, diabetes, CKD. These are all things that don't have symptoms necessarily. Diabetes certainly can, hypertension certainly can when it's very poorly controlled, but your diabetic patient, for example, who has an A1C of 8.5 or 9% might not feel anything. It's just their sugars are a little higher than average. Or the high blood pressure patients where their blood pressure is 160s or 150s, systolic over 90s. They won't feel anything. And with CKD in particular, it is really a laboratory diagnosis up until nearing dialysis, nearing kidney failure, because there's just no symptoms of it. And it's it's the silent killer because these things all stack on top of each other. And it's sort of the bedrock, if you will, of metabolic syndrome. It's the bedrock of cardiovascular death. And that's the leading cause of death in this country. So screening is important because if you don't know it's happening because you can't feel it, you have to be screening the population to find it. And the earlier you find all of these, high blood pressure, diabetes, and chronic kidney disease, the earlier we can intervene, the better the outcome across the board. My mom used to say an ounce of prevention is a pound of treatment. And screening is such a simple and easy test. It's so, so easy. A blood test and a urine test, and that's it. You can get it done in 15 minutes, and it's covered by basically every insurance plan.
I agree. Screenings are very important. And they, like you just said, it's covered. And there's also a lot of times those outreach programs that
Yeah.
nonprofit organizations do. There will be a whole day about, screenings and come out and it's free
Yeah.
for communities to take advantage of that as well.
In
Also,
Chicago, oh, I'm sorry, I interrupted
no,
you.
go ahead. Go ahead.
In Chicago, we have the National Kidney Foundation Kidney Mobile. It's a cute little van. It looks like a kidney, which looks like a kidney bean. That's why the kidney bean has its name. And we set up shop in different locations. For example, the Mexican consulate in Chicago. We have other areas too on the south sides as well. Where the CKD burden is particularly high, and we offer free screening, blood test, blood pressure test, urine test, and a kidney test. And 100% free. It's all about screening. And we are able to provide care for patients who need it. We can give referrals to local nephrologists, referrals to local PCPs for those who need it. And unfortunately, but we do also refer to the emergency department for those who genuinely need it. And it happens a lot more often than I would wish it would, but we definitely do have to do that. And there's other screening programs across the country that would be able to provide similar levels of care.
I agree, and that's really important. And thank you for, putting that out there.
Yeah.
So everyone, you guys know where to go. And it looks like a kidney bean, so you cannot.
Yes, looks like a little kidney bean cruising around. Yep.
Um, Also, too, I wanted to touch on. So, what are some of the biggest misconceptions people
Yeah.
have about kidney disease?
Yeah, I think number one is the one I hear in clinic all the time. So when I'm seeing as a nephrologist patients in my clinic, it's because another doctor has already identified that you have kidney disease. So they've done the blood work and the urine testing to show you have it, and then they're seeing me. So they've already made it past the screening. And patients are still, when I meet them, they'll say, my kidneys don't hurt. I don't feel anything. Is this really a problem? The kidneys don't feel pain like our joints feel pain. It's very different. Um, and the misconception, that's the big one, is that I'm not feeling anything, I must be fine. And that's again related to screening. Another misconception is once you have CKD, that it's not we can't do anything about it. And that's not true at all. There's most CKD in this country is not reversible, but it's manageable. And what I mean by manageable is appropriate diet, appropriate medications, avoiding further injuries to the kidney, promoting good health for what's causing the kidney issue. And in some cases, the injury to the kidney is reversible or treatable. And identifying those patients is important too. They're rare conditions. They're the conditions that physicians learn in medical school that are very rare. They're all named, but they're still important to treat. But even things like diabetes and high blood pressure, controlling those well really slows down the loss of function over time for kidneys.
Now, I love that you touched on that. And that kind of goes into my next question.
Yeah.
So, your work focuses on transitional care dialysis units. So, can you explain
Yeah.
how this model improves patient outcomes?
Sure. So, just taking a step back with CKD care, a lot of patients will meet a nephrologist after they meet their PCP and their kidney function is below 60%. But what does that number mean, right? So, our kidney function is based on a filtration marker called creatinine, and we convert that to a percent remaining function through a calculator essentially. And this has been, studied multiple trials, very large studies, to find this sort of equation that converts creatinine, which is a marker in our blood, into a percent remaining function. So most people have a kidney doctor when their GFR or their percent remaining function is less than 60%. Um, but patients are asking me, well, what's normal? Is 100% normal? The answer to that question is it depends. When we look at trials of patients who have no medical problems, so no issues at all, what we see is that the kidney function peaks at around age 20, which is kind of like everything else peaking at age 20 physically. uh, and it will stay there until about age 40. So if I'm meeting a 40-year-old, I expect their kidney function to be 100%. But every year after that, as a part of aging, and I tell this to my patients is, your back is not the same, your knees are not the same, things age, and our kidneys do too. Every year after age 40, your kidney function can decline by zero point 0.7 to 1%, and that's a kind of a variable number. So by the time you're 80, your function is expected to be 60%. So I always index their kidney function with their age based on that number. And diabetes, high blood pressure, heart issues, smoking, you can think of it as accelerating the aging of the kidney so that when you are, say, 50 years old, you may have the kidneys of an 80-year-old or a 90-year-old. That's kind of how I try and phrase it to help people understand that. Um, so as over time kidney function declines, we can develop symptoms. And these symptoms come up typically when your kidney function is less than 20%. So that would be CKD stage 4 is when a lot of people will start to have symptoms. And that's things like feeling sick all the time, nausea, vomiting, losing weight because you're not eating anything, having a lot of fluid on your body and swelling. Um, this is when we would have to start dialysis, where the kidneys are no longer able to do their job and we need to replace their lost function. And that's what dialysis does, is it replaces the lost function. It does not heal the kidneys, it doesn't help them in any way. It just replaces their lost function. So that transition time is really scary for patients because they have now an organ system that's not working and they need to be prepared to start dialysis. And unfortunately, in this country, just under 40% of patients will start dialysis without a plan. So they will either not know they have kidney problems, which is the majority of those starting without a plan, is they have no idea they have kidney problems. They're just feeling sick and they come to the hospital. Um, or they do know about their kidney problems, but it was identified too late, or their care was too late to make a big difference, and they need to start dialysis urgently. And these patients are typically admitted to the hospital. They have a temporary catheter put into their chest that allows us to clean their blood, and then they're discharged to a dialysis unit. So that's how 30 to 40% of our country encounters dialysis is not planned, unknown, no education, no experience, no conversations about this. Just you need to do dialysis or you're going to die. And I don't mean to scare our audience or anything, but kidney failure, if it's untreated, is universally fatal. So the patients don't have a lot of options. And they're kind of pushed into this system of you need to do this or bad things will happen, and they just make the decision that's easiest to them, which is frequently a catheter in the chest and doing in-center dialysis. But if you ask patients, where do you want to do dialysis? How do you want to do this? Almost everyone says, I wish I could have more independence. I wish I could work more easily. I wish I could do all these things. And we have programs available for that. It's called home dialysis. But they just didn't have the opportunity to even learn about it. They didn't know that it existed. They're in the dialysis unit getting dialysis, and they are just learning about this. So my program and our program at the University of Chicago is it's called a transitional care unit, and these are not new by any stretch. This is not like a new idea. Going back to the 80s, nephrologists were worried that patients were not selecting home dialysis at the rates that they should be, and these programs were just educational programs intended to improve home dialysis selection for patients. It's evolved over time, it's changed, but certainly the program here in the city of Chicago is new in the way that one, we're approaching it, and two, how we are implementing it and where. So this is targeting patients who are admitted to the hospital for starting dialysis, who are not aware they had kidney issues before, and they're going to be on dialysis until they either get a transplant or they change their dialysis type. So what we do is we intervene there and we educate them. We, discuss with them their opportunities, and we admit them to our program, which is an intensive 8 to 12-week course where they learn about dialysis, they learn about kidney function, they learn about the different ways we can do this, and probably most importantly of all, they get a referral to a transplant center, and they also get appointments to help set them up to make sure that we can move forward with their care. Um, this program's been successful. It's been successful at other institutions as well. Our unique twist on it is that it's a very urban center in a disproportionately disadvantaged communities is where we're focusing our efforts here on the south side of Chicago. Um, and these groups of patients, they do home dialysis at about 5%, and their transplant rate is less than half of what others are. Our program is getting the home dialysis uptake close to 50%, and the transplant referral rate is 100%. And 100% of patients complete their first appointment. So we're really trying to improve the outcomes for these patients.
No, this is amazing, especially that you're doing it in an urban setting. I think it's
Yeah.
very key and important that those folks have access to the care and the resources that they need. Um, and also, too, I wanted to ask, what disparities continue to exist in kidney care? I know you touched on it a little bit, but
Oh boy, yeah, that's a tough one. The reason I say it's tough is it really feels like the kidney care in this country is sort of the uh, the end game of inequality of healthcare in this country because it doesn't start with dialysis, right? Kidney care starts way back when you had normal kidney function. Wait years and years and years before you're, in the hospital sick with needing dialysis. It starts with having a primary care doctor who is sending the appropriate lab work, having the insurance to cover your appointments, having the opportunity to see the doctor, having the chance to do all the right things, and then also being exposed to the right kind of people around you to educate you and to support you. So, again, that's all preventative care. That's where this dialysis story starts. And then it only snowballs from there because if you can't see the doctors you need to see, you're not getting a screening done, your kidney function loss over time is accelerating faster than it would be if you were seeing people, if you were seeing the doctors you need to see. We have had medications on the market just in diabetic kidney disease since the late 80s that have proven to slow progressive kidney disease loss by 40% per year, reduces dialysis needs by 50%, reduces heart attack and stroke and heart failure by 40%. This has been around since the late 80s, and still patients are not on these medications when they have clear indications to do so. And this comes from just inequity in care, inequity in accessing care, and executing that care. So, and I'm not even talking about kidney care directly yet. That's just primary care stuff. And then when you move on to nephrology, what we're seeing is patients who maybe do need a nephrology referral are not getting it. Up to 30% in an academic setting are not receiving the referrals that they should probably be getting. Now, granted, that's a conversation between the patient and the PCP for getting that referral to see a nephrologist. But again, that's another step along the way where the inequity is still present. And then once they do see a nephrologist, again, do they have the time, the access, the means to do this? I see my patients every 3 months. That's pretty burdensome for a lot of patients, and they're getting lab work every 3 months. That's tough. That really is hard for them. And once they're approaching dialysis, if we're not able to stave it off long enough, again, having access to the educational resources, having access to what you need to do, it's all inequity and all inequities of healthcare. So it's not just nephrology care. It's all the way back towards primary care is when this starts. And then finally, once we reach dialysis, if you go to a dialysis unit, 7 out of 10 patients in that dialysis unit will be Black. And it's all stemming from way back here when we were not having adequate care early in their lives. And it snowballs into this. So, to answer, what inequities are, what's left in nephrology care, it's everything. Everything nephrology touches needs better and, more adequate care. And it starts all the way back from just first meeting the patient when they're 18 years old, screening them for diabetes, high blood pressure, CKD when indicated. So,
No, thank you for that.
yeah, yeah, very long-winded answer.
Yeah, no, no,
Sorry.
no, no, no. It was very, very good and informative, especially kind of back previous conversation we were talking to some of those health factors, depending if you're
Yeah,
smoking, also
yeah,
drinking too, that could make your kidneys age quicker.
yeah,
So how much are you doing of all these things will
right.
tie into, different health problems. So you might be 50, but your kidneys are 80.
Or 80. Yeah.
So I think thinking about those, and I didn't even think about that. So this is all, new to me,
Yeah,
um, and very needed. So thank you for the work that you do.
yeah,
I also kind of wanted to touch into your how you're teaching future physicians. I wanted to talk
yeah.
about that a little bit. So what do you enjoy most about mentoring medical students, residents, and fellows?
My favorite part, my absolute favorite part is seeing the medical students and the residents. The fellows already know the material that I'm going to be mentioning here, but seeing the medical students and the residents when I teach them kind of an underlying principle of physiology, and it's not just nephrology, it's wide ranging across the human body and how it works, teaching them something that they knew existed for, you learn it in class and that's great. But when you see it in person with a patient and you learn sort of the next level down, why is this happening? And you apply it to them, seeing that eureka moment when it happens is so magical to me. So that's my goal when I'm working with medical students and residents is sort of going to the older literature, the older textbooks that explained all these things that maybe they didn't fully appreciate when they were first learning, going back to that and explaining to them in real time and helping them understand it with a patient case and seeing it click and they get it. And everybody has it. It's an amazing experience when you get to see it. When someone understands something like that, it's really it's a gift to me to, be able to see it happen. And I'm sure they appreciate it too. So that's my favorite part.
No, I love that. And I think also too, like it's your journey is amazing, like all
Mm.
the work you've done and then being able to be in this role as a professor and to mentor them and like you said, that eureka moment, seeing, oh wow, I get it now.
Yes, yes.
Um, because we need more, physicians doing the great work. So also too, what qualities define an exceptional physician today?
So being a physician today, and again, I'm a younger physician. I haven't been practicing as long as my colleagues here in the section of nephrology, but um, it's not just medicine. Medicine it's not the easiest part. It's very hard, but navigating the social issues that patients deal with, because I can prescribe the best medication on the market for treating their diabetic kidney disease. Great. Is the patient going to be able to afford it? Do they have
Mhm.
access to it? If they do get it, will they take it? Do they understand why they're taking it? What are the common misconceptions patients have about medications? Can I correct those misconceptions? Are they even misconceptions? Maybe for this patient group, it matters a lot to them, this side effect. So, trying to navigate all of that because you can circle on a test. Diabetic kidney disease, first line treatment is XYZ. Great. That's super important to know. But how do you get patients onto XYZ? And that's sort of the art of medicine in many ways, is trying to navigate for them. So I think that's not, it's not the only thing I do as a physician, but it's a very important thing that I do.
I agree. And I also kind of wanted to touch on too, so as we're looking ahead in the future,
Yeah.
what do you hope kidney care looks like over the next decade?
So I'm very excited by the new classes of medications coming out. I'll use some brand names, Jardiance and Farxiga. They have generic names, but the reason I use the brand names is because that's what patients know. And that's what they're seeing commercials for. And that's what they're hearing on TV and what other patients are taking. Um, those medications in 10 years from now will be looked back on, I think, as almost miracle medications for how powerful they are for reducing progression of kidney disease, reducing heart attack and stroke, um, and hospitalizations. Very important class of medications. And another class that I'm excited about is everyone's heard of this one, Ozempic and Zepbound and all of its cousins. Again, I think in 10 years it's going to be what a miracle these medications came out. And I'm hopeful in 10 years that we have equitable access to all of these medicines. That's what I'm most excited for, and that's what I most want to see is that we get the medications to patients who need them. And then I don't ever want to overlook the importance of diet. My mom always told me you are what you eat. I think everyone's mom tells them that at some point. And it's so true. You need to be having a high quality diet. And the problem again in this country is inequitable access to high quality diets for everyone. I look at my dialysis patients and, they're 4 hours per treatment, 3 times a week in a clinic getting their dialysis. And, you don't just show up and get dialysis. You have to set up, you need to be prepared, and it takes an extra hour or so of time to do that. So it's 5 hours a day out of their lives. And some of them work, some of them are too tired after dialysis to work. So I need to tell them, yeah, you need to go home and buy expensive fruits and vegetables, and then you need to prepare them, and then every day do this. Or you can go to a fast food restaurant and enjoy I used to say $1 cheeseburger. That's not true anymore.
That
A
was
$5 cheeseburger or whatever. That is calorie dense and tasty, right? So I don't blame patients for that. But I'm hopeful that we can make progress on getting high quality foods to our population because that's what it's coming down to, I think.
healthy eating.
Healthy
It's very
eating.
Um,
alongside taking the appropriate medications. I can't emphasize that enough. These medications, I know people are frustrated by pills. I know people get frustrated by you're writing another prescription, but the excellent physicians out there are only writing medications that are clinically proven in trials, very large size trials, to move the needle in meaningful values. Heart attack, stroke, progression of kidney disease, dialysis needs, hospitalizations. These things matter to patients and they matter to us. So that's what they should be prescribing, and taking them has been proven time and time again to improve these things.
I think that's really important, taking your medications and also in addition to that, the healthy eating.
Yeah.
Um, and I also like how you touched on too the fast food. Uh,
Yeah.
getting a cheeseburger after doing dialysis, even though that's kind of contradicting the whole process, but
Yes.
what they have
Yes.
access to. Fruits and vegetables are very expensive. And some, depending where you live, you might not have access to get there, depending, if you have to take the bus or if you don't
Yep.
have, a car and all these other things. So,
Yep.
um, yeah, that's really important. And also, I wanted to ask too, so what advice would you give students considering careers in medicine or academic healthcare?
Yeah, so I'll touch on base on both. So for people who are interested in medicine, I would say you need to be passionate about taking care of people. That's many, many jobs. And being a physician is no different. It's a lot of training, it's a lot of expense to get through this process. And a lot of it is, I don't want to say luck of the draw, but the medical school admissions process is very tight. So making it through all these hoops and doing everything that's so, so challenging to do, and then also being passionate about taking care of patients because let me tell you, looking at charts, it's 6 o'clock on Friday, and I really want to go home, but there's stuff to do still, and you got to be passionate about it. Otherwise, you're not going to be happy. So make sure you are genuinely passionate about taking care of patients. I think a lot of people feel that way, and that's a good thing. As far as academics is concerned, again, it's a completely different animal to regular medicine. So there's sort of the private classic physician that a lot of people picture and working in a group and seeing different clinics and things. Academic medicine, you're training the next group of physicians, the next group of leaders, and balancing that with the research requirements and research interests that you have is challenging. It is hard because you still have the clinical aspect of it. But enjoy the challenge of it. And if you have the opportunity, so for those in medical school and residency, take up the gauntlet of writing a paper with a mentor, of doing poster presentations. I didn't know academic medicine existed when I was learning about everything, how to apply for, how to do this, because I just didn't have any experience. And looking back, writing that first paper with my mentor was such a big pivotal moment for me because I knew I wanted to do it. And academic medicine's changing. It's not just the older way of you are funded by a grant from a big organization. That's not how it is anymore. A lot of it's clinical with a spin of research and a spin of teaching. So don't be afraid to even consider it. I think it's a great opportunity.
Definitely. Yeah, and I love academia.
Yeah.
Everything I've done has been research. I will always push
Mm,
and the work that you do. Doing both of it combined is really important
yeah.
and wonderful to see. So now for the $1 million question, how can folks stay connected to you and the work that you do?
Yeah, so you can follow I would say what you can do if you want to stay up, in touch with what's going on, um, following the University of Chicago nephrology. I think we have a Blue Sky account these days. But we have our section manages our feeds and things like that. But I would say stay in touch with kidney care and stay in touch with recommendations from your doctor. That's the best thing I can tell you. Um, and if you're interested in learning more about my work, I do publish my work in journals. They're more niche journals. They're like clinical science of nephrology and these sorts of things. But that's the best be the best way to stay in contact with me.
Yeah, so guys, please take advantage of that and look at all those wonderful organizations that he just named. It's really important that you stay up to date on this um, because it's really important. So now I just want to say, Dr. Baseman, thank you so much for joining us today. Your work reminds us that transforming healthcare is not just about developing new treatments, but it's about improving education, strengthening systems, advancing research, and ensuring every patient has access to compassionate, high quality care. And through your leadership, your medical education, and community outreach, you are helping redefine what patient-centered medicine truly looks like. So, to our listeners, thank you so much for joining us for another episode of Breaking the Silence. And to learn more about our work, visit angelsprotection.org. And remember, silence protects systems, not people. So let's keep breaking it together. Take care, everyone. See you next time.
Thank you.